Can you unmute yourself?
I think I'm unmuted.
You are unmuted. You are unmuted.
Okay. So can everybody see
Joe,
my
a man
slides?
who needs no introduction. Joe.
Okay. This is Joe Cautilli, my third time back with you guys on doing this, and I hope we can continue to present our little blast from the past in behavior analysis. I'm going to present tonight on defining and integrating conceptual models of depression, behavior analytic and behavioral models of depression. For children through adults, it's a lifespan kind of approach. I'm going to be presenting data from all that. And looking at the idea of assessment and treatment. I just want to start out by saying behavior analysts and behavioral psychologists have a long history in assessment and treatment of depression. It's often missed in the world today. We have a world that went increasingly cognitive, and I want to make an argument that that was probably premature. But multiple behavioral models exist. Behavior analytic models exist, and behavioral psychologist models exist. And these vary and range from small to large effect sizes. I'm going to try to review each of these models in detail and then conceptually integrate the models on a functional assessment process that Jonathan Canner and myself, and a couple of his graduate students at the time, who've all gone on to be pretty famous people, actually worked on. And this kind of integration leads to very concrete methods for starting treatment. So my goals for this presentation, if it actually works out the way I hope it does, and it may not because we might not get as far as I had hoped, is that you'll be able to state the tenets and how to formulate depression from Lewinson's model of depression. I'm going to talk a little bit about how that flowed into behavioral activation. I'm going to talk a little more about behavioral activation than I talk about other things, largely because my initial studying when I was a behavioral counselor was in Lewison's model of depression. So I'm going to kind of focus more on that. But then we'll talk about other models, such as the coercion model of depression and the treatments that it suggests. Now, I use coercion theory for largely conduct disorder and oppositional defiant disorder kids. But there's been some work done with the coercive model, which is largely an escape conditioning model. It's a negative reinforcement model for depressive behaviors. I'm going to talk a little bit about the self-control paradigm that developed around depression. And then I'm going to talk about, again, how to integrate these models. But first, I want to convince you that depression actually is a real problem. There's some people out there that don't believe it is, but there are 17.3 million adults in the United States today that report that they've had at least one major depressive episode. That's 7% of the US population. The prevalence for episodes was higher among adult females, 8.7%, than it is males, 5.3%. But still, with males, you're talking 5 in every 100 having depression. The rates of depression are highest among adults that have 2 or more races. So if you're Latino and Caucasian, you tend to have a higher rate of depression. If you're African American and Caucasian, tend to have a higher rate of depression. You can fill in your own races there as you want. I also want to talk a little bit about this idea of depression in children. For a long time, depression was overlooked in kids. And even today, externalizing disorders and externalizing behaviors like aggression and rule breaking are a lot easier for teachers to spot than internalizing behaviors like depression or anxiety. And it's not just teachers, though. We've known since the 90s that physicians have had difficulty spotting depression in children. Most psychologists at one point would miss depression in children because they adhered to childhood depression was much like adult depression. And it wasn't until developmental psychologists came along saying, wait, this is an oversimplification, guys. And they suggested things like clinginess to the parent, refusal to go to school, expressing exaggerated fears and irritability may all be signs of childhood depression. So some other signs of depression to recognize are things like with older children, sulking, trouble at school, delinquent acts, many other behaviors that typically land a diagnosis of emotional and behavior disorder in school. So, how common really is depression with children and adolescents? Well, it's roughly 2 to 5% of the children in the school system today are saying that they're depressed. Um, it's if you look at children, just children as a group, kids under 12, 1% of them are expressing suicidal ideation. Um, so children diagnosed as depressed are much greater risk if you take it developmentally for adult depression than children who do not have a diagnosis of depression. Did not have a diagnosis of depression. We also know that at the young age, kids, children under 12, we see that boys are more depressed than girls. You're more likely to have boys depressed than you are girls. Then we reach adolescence, and lo and behold, girls switch. They become 1.5 to 3 times higher in rate of depression than boys. So it's an interesting kind of developmental phenomena that you see there. Um, if anything, I hope I've convinced you, if you're a behavior analyst out there, you're a BCBA, to grab some of your RBTs, turn them into depression coaches, and see if you can make a go and some money at that. We'll see. Now, I did this presentation to kind of give you links to some articles that I think are seminal articles. And I know that Tim had told me and promised me he's going to get you all my slides because it's important for me that research in depression and people working in depression continues. And that's a lot more important to me than, say, whether or not I'm the only one that has this set of slides. So I want my slides to go out there, everybody. I want the links to be active. I want to start talking now about Charlie Ferster. He was the first behavior analyst to look at the function of depression. He published an article in the American Psychologist, and I gave a link for that. And basically, he saw depression as a byproduct. It was a byproduct of lack of environmental reinforcement. And you're going to see that this idea of depression as a byproduct of either too much punishment or not enough reinforcement is one of the major models of depression. That if you don't have enough reinforcement in your life, you're going to feel depressed. We're going to talk a little bit about shortcomings to that model, but again, the idea is it's not direct, it's just that you're not having enough payoff in life in general. Lewinsohn then created a model in 74 that was largely based on principles from Charlie Ferster's work. Uh, and it looked at some of the idea of the lack of positive reinforcement. And that's due to things like loss, severe forms of loss, like somebody died that was very close to you. Redundancy, your life's boring, it goes over and over again. Relationship breakdowns, they all can lead to depression. Of course, if you're imprisoned, I know that Tim is interested in working with people in prison. You get high rates of depression for people who are in prison. Also, um, once the person is depressed, sometimes you'll see direct reinforcement of depressive behaviors. This was something Lewinsohn pointed out. They may receive sympathy, they may receive attention. I got the link there for Lewinsohn's article. I want to talk a little bit about Marty Seligman's work. Seligman started out with a very heavily behavioral model, a more cognitive interpretation of depression. Um, so basically, what he looked at was that depression was a function of punishment, and especially if that punishment suppressed operant responding. So the idea was if you took dogs and you put them on a shock grid, I'm not saying you should do this now. I know this would be unethical. I know somebody out there is going to shoot me an email about my mean comments about dogs. But if you put the dogs on a shock grid and you shock them and the shock is unescapable, they'll lie down on the grid and just kind of stay there. If you turn around and you take them then and put them in a room where they can escape by jumping into the next spin, the shock. If you compare dogs that have been shocked into the learned helplessness shock compared to dogs who have not been trained at all, you find that the dogs not trained jump out real quick. The dogs who have been trained that there's nothing they can do. They sort of lie there and it's unavoidable. And that's the model of depression. For some reason, my slide is not jumping to, oh, there it is. All right. So let me just go a little bit over Lewinson's formulation. It draws heavily on the functional analysis of depression conducted by Forster. It hypothesized that depression was either a lack of reinforcement or too much punishment. That is, a person was depressed because they did things that had little payoff for them, or they were receiving too much punishment. Uh, Lewinson's behavioral model of depression is a transactional model in that it's a person who engages in behavior that interacts with the environment. This means that depressed feelings and behavior are precipitated by changes in that environment. Once that's activated, depressive behaviors or elicit negative reactions and consequences, resulting in what you might assume is a vicious cycle, downward cycle. So low rates of response contingent positive reinforcement or high rates of aversive experiences, that's what precipitates depression. Once you have that cycle in play, you can start seeing negative consequences, depressed mood, depressed thinking, all being stimulated and further depressed behaviors being stimulated. Um, that's not to say that that's the only way you can get a depression. Lewinson himself pointed out that sometimes events that are normally reinforcing may become punishing. So a parent who engages in a lot of caring and directing behavior of their child, all of a sudden the child's behavior becomes difficult. The parent tries to change that behavior. The parent fails at changing that behavior. The parent becomes depressed, right? Now, this, you might be working with a parent who has a child with a developmental disability, and you find yourself having to work out some of the depression issues with the parent to keep them motivated to doing the program. It's very common in kids with conduct and oppositional defiant disorder to have that parent feeling helpless. Depressed persons could also have skill deficits that prevent rewarding interactions with others. Now, this is a smaller subgroup you're going to see later that have social skills deficits and problem-solving skill deficits, but they're definitely there. A shy person or an individual with severe communication deficits would fall into this category. Finally, an individual may lose the capacity to experience a potential reinforcer as pleasurable. Sometimes this is referred to as reinforcer erosion, and it could be a lot of biological factors there. It could be satiation, it could be biological factors such as age, those kinds of things. What's fun and exciting when you're 19 may not be fun and exciting when you're 45. I hope everybody kind of is aware of that. But, or when you're 55 and life gets even worse. But generally, empirical studies have shown that depressed individuals report experiencing fewer pleasant events and more negative experiences than others. And this is more of an important take home with that. Rehm in '89 showed that depressive symptoms begin to diminish in frequency and intensity as the individual reports more pleasurable life events and fewer aversive events. However, and I want to just state this, the causal connection between specific environmental changes and the onset of depression symptoms have not been well established. Self-report measures have suggested this link might be true, and I gave you a link to an article on that. But the model, this does not have the support that you would hope that it had for those particular variables. As a matter of fact, I'm going to talk a little later about some of the factors that kind of work against that reinforcement hypothesis. So what's this model suggest for treatment? Well, the goals of treatment in Lewinson's model are primarily accomplished by changing the frequency, quality, and range of a person's activity and social interactions. Beyond these general aims, specific treatment goals and strategies become highly individualized and collaboratively developed. Several characteristics of Lewinson's therapy apply to all cases, however. First, it's a highly structured and time-limited therapy in which the client plays an active role. The average length of treatment is about 12 weeks for Lewinson's model, but the model itself ranges from 1 month to 3 months. Finally, there are several discrete stages involved in the therapy context. There's initially an assessment and diagnosis phase, and it's necessary for determining the nature, severity, and subtype of the individuals presenting problems. And towards this end, interviews are used, direct observation is used. He would go to the home. I gave a nice little article on his observation techniques, and they did use self-report on depression. Uh, because the person sometimes can only see their own uh, own reaction. There's some private events that are only available to the one person. Next phase, if the depression is seen as the primary problem, the case conceptualization phase is conducted, where the rationale for treatment is being discussed. This is a very important phase because oftentimes depressed people will see themselves as helpless. They're victims of forces beyond their control. And the purpose of the conceptualization phase is to increase the person's awareness of how closely their dysphoric mood is tied to specific events. Through this process, the person's problems then are demystified and redefined. They're operationalized in a way to increase their perception of hopefulness and control. Once it's redefined, the individual's depressive symptoms become specific problems that then can be solved. Lewinsohn himself was very big on this case conceptualization phase. He said it really required great skill and sensitivity on the part of the behavior therapist. The redefinition of the problem has to be acceptable to both the therapist and the client. So if you're doing this and the client can't see this as them, chances are they're not going to follow through with the treatment. All right. But he did what he called a functional analysis. It's more related to today what we would call a functional assessment of the person's depressive symptoms being conducted. His method of functional assessment was comprehensive. Home observations. They would pinpoint specific behaviors and negative transactions that were going on in the home environment and try to bust them up. Clients are asked to fill out what's called a pleasant event schedule, and that's like a 320 item document, and an unpleasant event schedule, which is another 320 item checklist. They would take the top 80 events that were pleasurable and the top 80 events that were unpleasurable, and they would try to schedule the pleasurable events on the activity schedule, and they would try to limit the exposure to those unpleasurable events. The activity schedule then became part of this daily monitoring exercises. And mood and activity monitoring exercises were really used to further develop and redefine the treatment goals. Mood fluctuations were assessed using an instrument called the depressive adjective checklist, which is basically which of these adjectives describes you. And they had an unpleasant, pleasant activity record. Clients are taught to graph their data because it's a behavioral program, so they teach everybody to graph. But it was to graph the data from the daily monitoring in order to demonstrate the association between the client's mood and either the pleasurable or the unpleasurable events in a more concrete fashion. So in some ways, they were taking control of their own functional analysis process here. A wide range of methods were used in treatment to accomplish specific goals. Generally, these strategies fall into three categories: change aspects of the environment that are related to mood fluctuation. So if you know that depression usually followed, for example, a big argument with the wife, maybe talking about how to have less arguments with the wife was a thing to do for the guy that was depressed or the gal that was depressed. All right. The goal here in this first step is really just to shift the reinforcement and punishment density in the home. They want to teach concrete skills that can be used to change the negative environmental interactions. Depressed parents might be taught, for example, parenting skills designed to enhance the parent-child interaction. A shy individual might be given assertiveness training. Assertiveness training kind of came out of Joe Volpe's text on counter conditioning. It was an idea that you couldn't be anxious and assertive at the same time. And you'll see that there's an agitated depression that some people have where it's an anxiety depression mix. And assertiveness training works real well in that population. I'll talk about an article of that later on. Uh, they teach the client to enhance pleasantness and reduce unpleasantness for the environment. A lot of times they used relaxation training because the idea was this anxiety was incompatible with the feeling of pleasure. And it also enhanced the feelings of unpleasantness and made it more aversive. If a depressed client is seen as incapable of experiencing pleasure, the therapist then facilitates change that the client sees and speaks about the social experience they're having. For example, let me give you, you might do discrimination training between what's a positive and a negative event. What's a necessary and unnecessary activity to do? What's constructive versus destructive thinking? So you can see that there was a verbal component to this that was also part of the training program. Sometimes the therapist points out that some of the events change massive patterns of contingency, such as the death of a spouse or divorce. And there was, I don't know if you guys know Bruce Thayer, he did a lot of work with this guided mourning process, which was a behavioral treatment for death and mourning. Also, there's a lot of stuff done on exposure therapy for grief and depression. So there's some ideas that you can bring in other ways of therapy for these kinds of things. Although Lewinsohn would just tell people this is going to take a long time to kind of reestablish everything that those people provided to you. And there might be a little bit of, in your own life, a feeling of, I don't necessarily want to be whole again after they're gone. They meant that much to me. And so he would go over that and say that. So finally, towards the end of treatment programs, the client and the therapist develop an individualized maintenance and prevention plan to enhance treatment generalizability. Let me just say, there's been a lot of studies done on Lewinson's model of depression. There's been a lot of outcome studies conducted there. The 79 article that I put up there, they really just compared the three components: the verbal cognitive training, the pleasant event schedule, which we now talk about as behavioral activation, and the social skills training. All were short term and highly structured. The three components of Lewinson's model were all shown to be equally effective in reducing depression. This led to a course that they developed called the Coping with Depression course. It's a 12-week, 2-hour session spread over 8 weeks. It was shown that it could be done in group format, and the group format differences were very small compared to the individual, which then offered savings to the system. So now that I gave you the first model, it was a very promising model. Let me give you the first sack of the first model. Lewinsohn, Hoberman, and Rosenbaum, this was back in 88. This was when I was just coming into the field, provided evidence that contradicted the role of reinforcement. They looked at 500 non-depressed people for risk factors associated with depression. That is the reduction in reinforcement, negative thinking, life stress. And then they looked at them again 8 months later to see if they had developed depression. And they found that reduction in positive reinforcement really did not predict depression. Still, and they found out that behavioral activation was found to be very effective with adults. And I gave you 2 links there. You can look up those follow-up studies. And in a group intervention. Uh, uh, Don Beer did some stuff where he talked about the behavioral approach to depression, basically being relearning pleasure. Behavioral activation then was used to increase the amount of positive reinforcement and to relearn what positive reinforcement was. So you would have them put their predicted pleasure, and then when they did the activity, they would put their actual pleasure so that those rates would actually get closer. They were better able to predict their pleasure amount of pleasure they would get from an activity. I gave you a link there for a manual for relearning pleasure for children. And, again, I'm hoping that, it's a lot of stuff I'm going to cover tonight. And I'm hoping that if you are serious in working with depressed people, that you'll go back, or if you even have a client, say you're working with a kid that's autistic and the kid has some signs of depression or anxiety, that you'll develop these skills so that you can better work with that child. All right. So social skills training was for depression came out of this. It's geared towards teaching people how to engage in satisfying interactions, how to keep eye contact, start a conversation, maintain a conversation, how to make small talk, how to end a conversation. Even the basics of assertiveness and dating were covered in a lot of these early social skills trainings. They used to have programs on teaching people how to date, how to go on date. Later, social skills programs were expanded out into trainings, a variety of skills such as time management, self-monitoring, positive coping statements, and coping skills. The lack of social skills received some support in adolescent depression and in suicide attempters, and I gave a link there. And it also seemed to have a role in childhood depression. I gave a link there. These are the big thing on Lewinson's model was this idea of this pleasant event schedule that became behavioral activation today. These are treatment manuals that you can link to. I have one for Latino population. I have a bunch of them for adults and client manual as well as a therapist manual if you have an interest in learning more about behavioral activation. So where were we? Well, this was a Munoz and Cantor article, and they said the availability of research partially supports behavioral activation's pathology model, but lacks the technical precision and scope needed to provide more concrete support. Research examining the models longitudinally demonstrate loss of or chronically low levels of reinforcement that precede increases of depressive symptoms is necessary in order for the model itself to make more definitive claims, which was what I told you before. Lewinsohn kind of shot that down with his own study. There's also little research that supports behavioral activation's mechanism of why the behavior changes. And you could get that right from that link on the model. Okay, so again, this was the 80s and the early 90s, and people were doing a lot of studies on things like social skills for training versus support for people with depression. They found out if you take adolescents, you throw them in a social support group versus giving them social skills training, the social support group jumps right up in decreasing depression, and the social skills training lags. Then what happens is, as you would predict from the model, the social skills training catches up. Now, a lot of people then were saying, well, why doesn't it surpass the social skills training, the supposed social support group? And the idea was, well, it's not necessarily the case it would surpass it because while the social support group gives you a lot of freer reinforcement early on, people do socialize you in those groups and they train new behavior on your part. Right, they say that this might be bad or this might be good. But like I said, social skills training in general has a small effect size. Well, how small is the effect size? It's about the same effect size as cognitive restructuring, and some studies have actually found the two to be equivalent. Early meta-analytic studies in the 80s and 90s showed a combined treatment of cognitive and behavior therapies for depression to be slightly more effective than either the behavioral or the cognitive therapy. This is an article with a link like that. But I want you to look at table 5 in that article when you get the time. You see that in the head-to-head, the behavioral activation versus the full CBT training, the difference there is 0.2, which is a very small effect size in a meta-analysis. And it probably wasn't the best way to go to link and abandon behavior therapy over that. It probably would have been better to look at how can we strengthen behavior therapy rather than grab it and throw it into the CBT, where you have two models that don't really kind of gel well together. Compounding that problem is if you look at table 4, you see that the largest amount of those studies were done for CBT superiority were done by people with a CBT orientation. So they talk about a thing called allegiance effects when you do meta-analysis. You find this often when drug companies do meta-analytic studies. All of a sudden, their drug kind of always comes out as being the best one. And the reason for that is people tend to gear the outcome measures towards what they know their drug does. Same is true, I think, in the behavioral literature. But if you go to table 4 for the unweighted effects, you see that BT has a very large effect size. compared to CBT, which only has a moderate effect size. So if you don't look at CBT to behavior therapy head to head, you just compare what's the effect size for CBT and what's the effect size for behavior therapy. You see behavior therapy has a lot larger of an effect size. Now, this led to a lot of discussion because, again, it was the Times. I mean, the big agency that was doing the behavior therapy versus cognitive therapy was Association for Advancement of Behavior Therapy, with their largest membership being CBT people at the time. So you see that you actually got arguments that were really poor arguments made. Like Hollins made the argument: it doesn't matter what the real mechanism for depression is, because we all know that if you do behavior therapy, the effect is indirect. That is, that it eventually has to change the cognition for behavior therapy to be effective. Now, some of the behaviorists at the time made the exact opposite argument. They said, well, wait a minute, that's really a bad argument. Maybe cognitive therapy's the indirect effect, and the only way it gets a direct effect is because it gets people to self-control wise change the contingencies in their life. So it's a chicken and egg kind of story, and it's whatever you want to believe. Um, so what's the big treatment then? After a brief wetting of the cognitive and behavioral approaches, we started seeing that there were studies being done out, one by Neil Jacobson, where they just did component analysis of the behavioral activation versus the cognitive therapy versus the antidepressant medication. And they found out that the largest controlling variable really is the behavioral activation piece, and that there was very little, if nothing, added to the cognitive piece at all. This is an article, again, behavioral activations had so many studies now showing its effectiveness. This is an article that combines behavioral activation with collaborative goal setting with elderly people, and it's done completely by phone contact, and they show complete decrease in depressive symptoms. So how big is this behavioral effect size here? And so that's what people started to ask. There was lots of studies developing, and this is the early 2000s. Back in 2006, the behavior analysts today received the first meta-analysis ever to be done on this subject matter. And they found that out of these 8 studies that were done, 6 of the 8 studies reported very large effect size, greater than one standard deviation on the BDI. That's the Beck Depression Inventory 2. At scores of post-treatment, and 5 of the 6 reported a very large effect size on follow-up. When you look at the Hamilton Rating Scale, which is another measure for depression, Beck's depression scale more skewed towards cognitive things like what people tell themselves about depression. The Hamilton more skewed towards physiological symptoms, those vegetative symptoms. You see that the effect size ranged from very large, right, an 8.83 to 3.29 at post-treatment, and very large on follow-up, like 9.6 to 2.48 on follow-up. All 7 studies utilizing the Hamilton reported a very large effect size at post-treatment and on follow-up. And there's a link to that. Now, since that meta-analytic study came out, there's been 4 meta-analysis that have been done. There was even a meta-analysis done that showed a very favorable review of behavioral activation for children and adolescent depression. This is from one of the articles, and it's the links there. Random effect meta-analysis of symptom level post-treatment show behavioral activation to be superior to controls and to medication. But the overall study quality on the majority of studies is low, and the follow-up periods tend to be very short. So you weren't getting 2-year follow-ups on the depression cases. You were tending to get 3 to 6 month follow-ups on depression cases. Okay, so what happens after positive reinforcement does not predict the etiology? Well, the reinforcement study that looked at reinforcement by collapsing it across participants, that's a reinforcement density model. A lot of times those studies themselves have problems because reinforcement is an individualistic kind of phenomenon. In other words, it's not the behavior that I can do in the abstract that's the most effective behavior. It's the behavior that me as an individual can actually produce in that functional situation. So a matching model of reinforcement may produce better understanding of the role of reinforcement. In addition, the byproduct model of reinforcement is actually one way to see it, uh, especially if you want to combine it with this idea of high rates of punishment. So I'm going to talk about punishment now, and I'm going to talk about escape from punishment as the coercion model predicts, which is sort of a negative reinforcement. All right. So when we talk about the role of punishment, depressed individuals were found to elicit more negative reaction than others. This combined with several studies that showed that depressed people had more aversive events in their lives led to a revision of Lewinson's work. Again, the cognitive model isn't that the events in your life disturb you, it's your interpretation of the events. I would argue, based on Munoz's work and Billings' work, that no, actually, depressed people really do have more shitty lives than people who are non-depressed. And there's some clear evidence that supports that in a good number of cases. But anyway, Lewinson revised his model to see that both external and internal forms of punishment were taking into account for causing depression. For kids, punishing events became very much focused. Gerald Patterson and his colleagues over at Oregon Social Learning Approach presented a path, and they replicated the path model of academic failure and peer rejection as a model for childhood depression. In other words, this idea that the aversive events of being rejected by your peers and failing academically predicts depression in kids. I mean, this is not brain science here. I could have told you that without having to do a complicated path model, but he got money to do it. So that's the difference. Um, although I should point out the academic failure proved to be less stable and more variable. So people don't care as much about their academics at school as they do as much as the other kids are bullying them and teasing them. But as we move now to escape conditioning, escaping aversives, I really want to point you in the direction of this chapter by Hops and Biglin. This is a very good chapter. I would suggest you get it if you want to work in this field. It really lays out the coercive model of depression. In coercion theory, family mechanisms support the development and maintenance of depressive behaviors and symptoms. This theory is an interpersonal depression model, like Lewinson Förster theory. Coercion holds that the interaction patterns with salient context are critical areas for study and key targets for change. Coercion theory is a microsocial interaction theory. It conceptualizes the individual's behaviors under controlled social environment, and at the same time is operating as a context for behavior of other social agents. Coercion theory holds, Lewinson kind of put self-report instruments on the level of direct observation. Coercion theory held that the idea was that, yeah, direct, what's his name is important, but really direct observation is the most important variable, because people aren't going to come in and tell you if they're getting subtle reinforcement. I'm depressed because it makes my wife stop screaming at me, right? If I get depressed, and it suppresses my wife's anger. People rarely say that. The data for Lewinson, for coercion theory, was collected by observation. It was put into a stream model of social interactions, and they identified the social contingencies that may have been controlling the coercive behavior. The theory holds that depressed people live in aversive environments that are conducive to the development of depression. Behavior of depressed persons is aversive to others and constitutes a salient stimulus for response. Depressive behaviors are functional and reducing aggressive behaviors of others, like aggression, as well as eliciting positive social consequences, like sympathy. All right. Review of the literature seems to support the first assumption. That's the Billings and Muse article. They found that depression, yes, indeed, was people depressed live in more stressful and aversive events, and they have fewer positive events in their life. Interactional studies have shown that depressed individuals receive more negative comments in conversation with non-depressed counterparts, as well as receive fewer reinforcing behaviors such as directly positive supportive statements. Hobson and his colleagues found that higher rates of irritability affect children of depressed mothers when compared to non-depressed mothers, particularly when maternal depression was paired with marital distress. Second, evidence exists suggesting that depressive behavior is aversive to others. Depressed mothers have been found to be more aggressive than normal mothers in laboratory interactions and more dysphoric and less happy during family interactions at the home. So to the third issue, Hobbes found that depressive behaviors have functional characteristics. It was to reduce aversive behaviors of other family members. So if the child's mean, the mother gets depressed, starts crying, the child may give up the meanness. They used sequential analysis to demonstrate that this pattern was consistent with a negative reinforcement paradigm. So if you're interested, and if you're in grad school and doing a doctoral program, this is an excellent study to replicate. And that's basically the summary of all this on coercion. That's a 2002 chapter in Reed and Patterson's text. All right. It appears that while coercion predicts antisocial behavior in both boys and girls, by adolescence, we see girls are much more susceptible to a depressive symptoms by this escape conditioning model than boys are. All right. So boys kind of get a little harder as they all get older. Maybe that's why they're more likely to become conduct disorder and then go on to becoming antisocial, whereas girls tend to become more depressed in the same coercive cycles. All right. So what's the treatment then from the coercive model? Well, disrupt the family coercive practices, reinforce the use of competing behaviors for the parent, child, or adolescent. These factors can be accomplished in several ways, including parent training and family therapy. There's been a lot of studies that have shown, there have been some studies that have shown that when you decrease the antisocial behavior of the boys, when you disrupt the coercive cycle, antisocial behavior and depression in boys both decrease. But there are overall very few studies and very few meta-analytic reviews on the subject matter. All right, so let's move from positive reinforcement and escape conditioning to this concept of rule-governed behavior. Somebody brought up rule-governed behavior. I believe it was Dave tonight. There have been many models of rule-governed behavior that have led to treatments. We had self-control, and there's self-control from a behavioral perspective like Camphor and Golddiamond did. There's self-control models from a more cognitive perspective. Skinner studied problem solving, which is the development of kind of rule-governed behavior. And you saw that in the 66 paper. He held that problem solving was the basis by which we develop rules. You can read that. On the other hand, you had Zettel, who did some interesting work on problem solving skills from a cognitive perspective. We see then this first rule governed behavior, developing rule governed behavior model coming out. We see Art News conduct a research on the idea of helping people to develop better problem solving skills. Immediately, research started to develop into a treatment, and it was very positive. He also did some research that showed it was not just the task of the problem solving, but also the cognitive level, the orientation to the problem that were very important in training problem solving. For those of you out there that are treatment oriented, problem solving training is first a problem identification phase, where you help the child or adult define their complaints, identify various components of the problem. Then you have them identify how they handled the problem in the past. Then they generate alternative course of action. This is usually like a brainstorming phase. And then they take each course of action and they weigh the advantages and the disadvantages. They make a decision to select one and try it, and then they contract with the therapist to do that. If you're looking for a manual on problem-solving training, it's right there. As research accumulated, so did meta-analytic studies. One meta-analytic study found small to moderate effects for problem-solving training One found it to be equal to other psychosocial treatments and to medication. And then one found mixed results, and they couldn't say. With children, problem solving was found to have moderating effects on environmental events and depression in children. So problem solving was both shown to change the environmental contingencies as well as decrease depression in children. I gave you the link to that study there. Self-control is not new to behavior analysis. Like I said before, Israel Golddiamond took a hack at this back in '65. I give to a link to that. The idea from a behavioral perspective is that a person might need to give up some short-term reinforcer to move to a long-term reward. Skinner talked a little bit about this in his Walden 2 novel when they gave the child a lollipop, told him to put it in his pocket. If he had not licked the lollipop at the end of the day, he got to keep the lollipop. If he did, he was not, the lollipop was taken away from him. Is there any support for this idea that depressed people have this thing where they lack reinforcement? We found a tendency, Rehm did, to prefer immediate reinforcement to long-term reinforcers for subjects who were depressed. And I gave the link for that. So this led to behavioral self-control programs. Some of those programs included behavioral problem solving as treatment of depression. The initial studies with children found this approach to be effective for moderately to severe children. Rehm's models developed on Camper's model, self-control. Basically, the argument there is that the world is training them to respond selectively to negative events. Their life is, they become more salient. They attend to immediate rather than delayed outcomes. So there's a tendency for the immediate reinforcer and a failure to develop rule-governed behavior. Setting perfectionistic standards for themselves, goals they cannot attain, and making attributions that are consistent with negative expectation. And there's an insignificant amount of self-reward and high levels of self-punishment. So Rehm's treatment's time-limited, highly structured group therapy focused on remedying specific skill deficits. Clients participate in 6 to 12 90-minute weekly sessions that are highly didactic in nature. During the self-evaluation phase, planning and decision-making activities become really the focus. You see a lot of discussion on homework. You see a lot of collaborative goal setting. I'm trying to speed it up because I know I'm running out of time. And you could read a little bit more on the model. When the model was first laid out, there's a link to that. Rehm self-control model is considered an evidence-based model for depression. Studies did show that depressive symptoms were reduced in only 6 weeks, and the gains were maintained on a 1-year follow-up. There was no difference found for his self-monitoring component versus self-monitoring plus self-evaluation or self-monitoring plus self-reinforcement. They were all equally effective. When compared to psychoeducational groups with elderly people, the model was found to be very effective, but not more effective than psychoeducation. They were also self-managing and self-control therapy seems to be equivalent in children to behavioral problem-solving therapy, and there's a reference there. Too much rule-governed behavior could be the other end of it, and I talk a little bit about acceptance and commitment therapy here. The idea is the basic research on rules supports the notion that people will give up a lot of reinforcement, immediate reinforcement, to follow the rule, and that this can actually lead to some length of treatment. But the most recent meta-analytic studies on ACT as a treatment have pointed to only a moderate effect size for depression. So compared to others, controls ACT is superior after treatment of 1 to 3 months for depression. And there's the 2 links for ACT treatment depression manuals. There are a lot of other models. I don't want to kind of go into them. We developed basically an idea saying, well, and this, you could get this on the link. That's the Cantor article I did with Bausch. And the idea, the take-home message here is your success in depression treatment might be enhanced if by understanding environmental factors that impinge on the client. So We have the byproduct models of not enough reinforcement, like Fester and Lewinsohn, too much punishment, like Lewinsohn, a loss of effective operant behavior. That's your learned Helmholtz model uh, from Seligman. So if you assess your depression, you can find it on any of those three. There are direct operant models, such as a positive reinforcement model or a secondary gain model for for depression, which you see played a role in Lewinson's theory. And then, of course, the negative reinforcement, which is the coercive model. And then the two rule govern models, the building of rule govern behavior from Rehm and Niezu, and the too much rule govern behavior from ACT. And then other environmental factors we talked about that might precipitate depression, like establishing operations. Again, I don't want to take too much time on this. I'm kind of jumping ahead. These are some assessment instruments I lay out if you're interested in basically how to conduct a behavioral activation schedule. What does an environmental rewards observation scale look like? What's a reward probability index? Once you've got your assessment done, you move to formulation. And as you can see here, for example, I just want to take one case. For example, if you have, I got like 5 cases here, but I'm only going to take one. If Johnny is depressed, in your formulation, you posit and then observe depression is largely in the form of Johnny feeling tired all the time. In the morning, he has great difficulty getting out of bed. You observe that when he gets to school, he's frequently neglected by most of his peers, except for certain groups which tease him. This formulation might suggest that difficulty getting out of bed might be the result of escape from the teasing and too little reinforcement. This might be a kid you train in assertiveness. You might train some problem solving skills with him on how to deal with teasing, do some social skills training on how to make friends, and set up your behavioral activation program. Okay, and that was basically, these are just some forms on behavioral activation program. And I know that I'm getting too late. So let me go back, turn everything back over to you if there's any comments.
Yeah, thank you, Joe. And I will say we are really out of time right now, but if anybody wants to ask anything, uh, the three of us are still here. Dave had to leave, but we're really at the 8:30 mark right now. So if you have to say goodbye, I understand. But if there's anybody that wants to ask anything, go ahead and just unmute yourself and ask away. Nobody? Uh, oh, and I think I can. Can you stop sharing, Joe? Because then I can see the whole screen.
Let me see if I can stop sharing. How does that work? Are you still seeing my stuff? Because every time I
I
go
still see it.
okay.
Matter of fact, yeah.
There you
Right.
go.
Anybody want to ask anything? I heard a lot, Joe. I hear a lot of people that if you want to just conceptualize depression, it is just negative thinking. If it is anything,
I don't
that's
know.
pretty. I mean, that's
That's
I think
ingrained
it's
in our
pretty.
society. I
Yeah.
think that that's actually a misconception. I think if you look at the data, look, cognitive therapists wanted to say that for years. It's all about how you think about the situation. But the truth is, depressed people have pretty depressing lives. So is it a chicken or an egg phenomenon? It might be that, as the cognitive therapists have argued, it is all in your head, and that once you change how you see the world, things get better. Or it might be that you really have to change the contingencies in your life. And as you do that, your depression will lift. So it could be a chicken or egg argument. I don't think that the effect sizes from the meta-analytic studies supported the idea of integration with cognitive therapy when they did. But like I said, ABA at the time was not a practitioner organization, Association for Behavior Analysis International. They had more concerns about getting their own students jobs and research that wasn't happening. So they didn't have any time to take this battle up. And certainly the biggest population outside of that were developmental disabilities. So you had AABT, which was largely supportive of, integration. As a matter of fact, Joe Volpe used to call it the Association for Eclectic Recipes. That was his little knock on it back then.
Okay. Somebody unmute. Want to ask something? Okay. Well, if there's nothing else, Dave's not here, like I said, but I've already thanked him. I thank Mike, Bill, Joe. I think it was an incredible talk, a lot of useful information, useful to any area of ABA, I feel is what we had here tonight. So I can't thank you enough. This has been our third installment, and it'll be available out on YouTube and out on our Facebook page for novel applications of ABA webinar series. And at this point, I think if no one else has anything, we can say our goodbyes, and I'll tell you all to have a great night.
Have a good one. Thank you all.
Take care, everybody.
Great,
Thanks a
great
lot.
job, everybody.
Bye.
All right. Take care.
Bye now.